Thank you for joining us on ESOTA TV. We had a very exciting large clinical trial session today with many positive results. And we would like to maybe hear your thoughts, Simona, about the INTERACT-4 trial, which was just published in the New England Journal today.
Yeah, I think that the INTERACT-4 trial was a very important and very interesting trial that can really impact our clinical practice and probably also future research. This was a trial to understand if blood pressure lowering in the pre-hospital setting can improve a stroke outcome. And patients with the stroke were randomized in the ambulance to receive blood pressure lowering in the ambulance or at hospital arrivals. The trial included the patients with the blood pressure above, systolic blood pressure above 150 and that had the symptom within 2 hours. And findings of the study are very interesting because the overall effect on the primary outcome, the change in modified ranking scale score was neutral, but there were interesting findings if we look at subgroups, and particularly if we look at patients with ischemic stroke and patients with hemorrhagic stroke, because the studies showed that patients with hemorrhagic stroke receive blood pressure lowering can have clear benefits from this treatment, whereas the patients with ischemic stroke who receive blood pressure lowering in the ambulance can be harmed from this treatment. I think this is something that, well, it's hard to be translated in clinical practice very, very soon because most of the ambulances don't have a CT scan. But I think that it can reinforce the concept that in ICH we have to lower blood pressure as soon as possible. And probably this study can impact also future research. Now we understand that we need to differentiate ICH from ischemic stroke even at the ambulance phase. And so it's a time really to move forward with the mobile stroke units, but also probably in developing some sort of biomarkers that can allow a rapid differentiation of those two conditions.
Absolutely, yeah, that's true. It does increase the importance of the pre-hospital phase again. Yeah, very interesting. And then once we've heard this morning, very interesting morning, that when patients arrive at hospital, there was a phase 3 randomized controlled trial presented, the original trial, tenecteplase versus alteplase in Chinese patients with acute ischemic stroke. Georgios, what do you think? What was your conclusion?
I think this was a very important trial. It was the 4th phase 3 randomized controlled trial in patients with acute ischemic stroke. The previous 3 were ACT, TRACE2, conducted also in China, but with a biocopy, not the original TNK. And there was a 3rd trial, ATTEST2, that was conducted in the United Kingdom. This was a non-inferiority trial. So this is the 4th trial showing consistent results that tenecteplase is non-inferior to alteplase with regard to the primary outcome, which is excellent functional outcome defined as MRS score 0 to 1. The dose is identical in all 4 trials, 0.25 milligram per kilogram. And also there was a trend towards numerically higher rates of MRS score of 0 to 1. 3% risk difference, and also a trend towards better functional outcomes in the SIFT analysis. There were no safety concerns with regard to symptomatic intracranial hemorrhage and intracranial hemorrhage and mortality. The rates were similar between the 2 groups. This was a large trial randomizing approximately 1,600 patients, so I think it provides additional high-quality evidence that we can start thinking switching from alteplase to tenecteplase.
Yeah, yeah. Yeah, that's perfect actually, which because we have that shortage of alteplase, but also tenecteplase, but that both together might make it better in the future.
Yes, we now have enough evidence to use tenecteplase in daily clinical practice, and we are waiting for the results of the updated meta-analysis with these new trials. Speaking of tenecteplase, there might be now the possibility to treat patients, very selected patients, beyond 4.5 hours, maybe up to 24 hours. And these are the very intriguing results of the TRACE-3 trial. What do you think, Simona?
Yeah, I think that the TRACE-3 trial is very interesting also because it addresses a peculiar population. That is the population of patients who have an ischemic stroke, who have a large vessel occlusion, but who cannot access to thrombectomy. And so for those patients, there's an unmet need to fill. The study was performed in China, and patients with large vessel occlusion were randomized to tenecteplase or to the standard of care. The study was performed in the extended time window, so patients who had their stroke from 4.5 hours up to 24 hours, and the selection was done using the iStroke software, so a software to identify a perfusion mismatch. And overall, the study showed that the treatment with tenecteplase can significantly improve the prognosis of patients. So there was a high proportion of patients with minimal or no disability in the treated group. And so this really can open the window for a new approach. Of course, we have to consider that the study was performed in a single country with a very peculiar organization that may be different from other countries, and so probably we need to replicate something similar in a study performed in different settings, different countries, to understand if this may work.
Thank you. It's really interesting to see this positive trial in contrast to the timeless trial, which was recently published and was neutral.
Yeah. And I mean, hypoacute treatment is very important, but we also heard important results today about management after endovascular treatment. We could hear results coming from clevidipine infusion for blood pressure management after successful recanalization. Georgios, what is your impression? What does that help us to decide in reality?
Yeah, this is another important trial, and which was conducted in the US, and the investigators randomized patients either to intensive blood pressure lowering using clevidipine, a medication that is a calcium channel blocker with very fast action, compared to standard blood pressure control as recommended by current guidelines. So this is like the 6th trial that shows that after successful reperfusion following mechanical thrombectomy, we should not bring down blood pressure aggressively. It was very clear that the hypothesis was that with aggressive blood pressure reduction, there would be a lower risk of symptomatic intracranial hemorrhage. There was no difference in the hemorrhage rate, but numerically higher numbers of disabled or dead patients in patients with intensive blood pressure reduction. So I think this is an important message that we shouldn't touch blood pressure after a successful reperfusion in terms of aggressive blood pressure control.
Yeah, we have to be patient and wait and give the brain a chance to recover. But also, when we come back to endovascular treatment, if we can have just some quick words on the results presented of the Mr. Clean No IV study, that RCT, which investigated whether we shall do intravenous thrombolysis before endovascular treatment in patients with tandem versus no tandem occlusion.
Yes.
What do you think? That was quite interesting.
Very interesting. This was a pre-specified analysis, and there was the hypothetical risk that in patients with tandem ICA, MCA occlusions, there may be a high risk of pretreatment with intravenous thrombolysis because these patients may need stent and antiplatelet therapy, so there is a high risk of hemorrhage. This was not shown in previous trials, in SWIFT Direct, for instance, but the investigators of Mr. Clean No IV presented very convincing data showing that patients without tandem occlusions, they benefit significantly using intravenous thrombolysis. However, on the other hand, patients with tandem occlusions may fare worse if they receive pretreatment with TPA. Of course, a word of caution, this was a pre-specified secondary analysis. The IRIS collaborations are performing an individual patient data meta-analysis that will address this specific question, and we will await the results because they're discrepant between the different bridging trials.
So blood pressure reduction at the acute phase is definitely a hot topic, and this was also covered in the TRUTH observational study, which shows very thought-provoking results. So could you please tell us a bit more about this and whether we need to change our practice right away or not?
This is an important question, and the study has just been presented and published in Lancet Neurology. I think it will be very important to go through the papers and understand in detail all the methodology and all the results. This study addressed the question of blood pressure lowering in patients who are undergoing revascularization with intravenous thrombolysis, because we know that guidelines recommend to use a blood pressure lowering and lower the blood pressure before the thrombolysis if the value exceeds 185 over 110. And so this was a cluster-based parallel group study. There were centers that used to treat high blood pressure before thrombolysis, and centers that used a more conservative approach. And how can I say, probably surprising result is that by lowering blood pressure does not lead to a better outcome. Of course, I think that this result should be interpreted with caution, and we have to read the paper, but probably this cannot change our approach and our guideline. We have to remind that the study was not randomized. There was a discrepancy in the numbers of patients who received the conservative approach or the blood pressure approach. So I think that it can generate one hypothesis, but cannot change our practice.
Yeah, exactly. I think that is very important. It's interesting, but we have to invest much more research and before we decide on how we go on and what we change. I would like to thank my dear colleagues for standing here together with me and discussing this very interesting morning. I would like to wish you a very nice rest of the conference. And we now change the topic. Thank you. We change the topic. We stay in stroke research. And there is a group of colleagues coming, and we will discuss clinical trials, trial networks. Why do we need that? How can they help us to do more stroke research? We will have Sprigg coming from the University of Nottingham. He was a very experienced trialist. Hello, Nikki.
Hi,
nice to see you.
Nice to see everyone.
Pooja Kathri from the University of Cincinnati in the USA, also very experienced trialist, and she's here as co-chair of GAINS, of the Global Alliance of Independent Stroke Networks. We've got Mayank Goyal here from the University of Calgary. He runs an organization which tries to improve funding for stroke research, and Mayank Goyal, the chair of ESOTA, the European Stroke Organization Trial Alliance. Hello, Jean-Marc.
Yes.
Welcome to this session. So, interesting, lots of research we've heard this morning. Nikki, what do you think? What is your impression as trialist? How can stroke research go on?
I mean, I think what we've heard this morning is some really exciting data, but nearly all of it, we've said it needs validating in different representative populations, and that's why we need these collaborations, the European, the global alliance, because we need trials that include everyone and that represent patients around the world. And then we need interventions as well that are suitable for high income and low income and deliverable in different healthcare systems. And I think these collaborations bring us together, share knowledge about the different methods of trials, different sites, different recruiters, and foster good practice. So I think it's not possible for us to change practice now with single centre or even single country or region trials. We need truly global
That
research.
is very true.
Yeah.
Jean-Marc, do you want to introduce ESOTA?
So ESOTA has been funded almost 10 years ago, and it aims to regroup all the national network of the European countries. So far we are 15. We are trying to investigate and facilitate the possibility to get funding from the academic nationally, getting through the different regulation that sometimes can make things a little bit difficult. And we are trying also to expand to all the possible European countries and help them to set up their stroke research network. And on the other side, we're starting to have a very productive meeting with GAINS. So we'll have an introduction about that by Professor Kathri. And we do think that it has been just mentioned that right now it will be very difficult to demonstrate efficacy if we are not able to recruit patients in many countries and also to reflect our different practices, as it has been illustrated a few minutes ago at the conference.
Yeah, GAINS, that's a very good keyword. Pooja, can you describe what GAINS is? I think many of us have never ever heard anything about GAINS, but actually it's very important for stroke research.
Yes, and I appreciate the opportunity to talk about it because we want more membership. But basically it's a loose alliance, a network of networks, a global alliance with the idea that to kind of facilitate, strengthen, and nurture relationships between what you might say are clinical trial wonks. In other words, people who really love thinking about clinical trials, the process, advocate for efficiency, and learn from each other and work together, as well as build the next generation. So,
very often, actually, I get asked, why do you actually need networks of networks? Experienced trialists, you might know that you know each other. You can just either phone, email, text on WhatsApp, and ask your colleagues whether they want to join your trial. What do you think, all of you? Why do we need networks, and why do we then need networks of networks?
We need to be more inclusive. We can't just go with the people that we used. Yeah. I mean, that's what used to happen, and we're all learning that we just can't do that anymore. So, yes, there are some helpful contacts we already have, but you know, there's an untapped resource out there of patients and researchers and clinicians as well. I think that's the good thing with these networks. They link with clinical services as well, because we need to be able to find patients in clinical service. Sorry.
Mayank, you are in Canada.
No, I completely agree with what was just stated. Like, the reality of it is that one thing it's sort of a pet peeve of mine is that to do a trial with inadequate sample size, and at the time of design of the trial, we sort of brainwash ourselves into thinking of an over-optimistic effect size of whatever intervention we are trying to do, and we sort of design a trial based on a sample size of convenience rather than on the principles of MCID. Yeah. So that is sort of I completely sort of agree with that.
Yeah, that's true. That is true. We always consider, is it doable at all? And we probably sometimes reduce our expectations of it. And where do you see ESOTA and also collaborations with GAINS, Jean-Marc?
I think it will help us to get more weight and more being make the stroke something more important to get funded. We are trying now to use our network to get an estimation about how stroke research is getting funding and how this could be improved by comparison to other diseases and by comparison to other expenses. And we do think also that being together is also helping young and promising researcher to strive more rapidly in contact, because they don't have the contact by definition sometimes. And so they would have the contact, they would beneficiate from the experience of Mayank, of Pooja, Kathri, of Sprigg, to help them to build a productive trial. So I think it's very important.
I think that is quite good to discuss that funding point. We had 14 large studies and trials this morning, and more than half of them had to terminate earlier because of a lack of funding. So where does that lead us to? What do you think?
It's
shocking, actually.
All the more important. You know, it's always been tough, but then when we added in COVID, we really dragged out our money. And you know, I'll just also add that, you know, in terms of bringing us all together, there's, as you were saying, about just being inclusive, about small effect sizes, about the power in numbers for getting funders together and talking about the issues. And some of the concrete things that we can do is work together to create early career workshops, which we've been doing, as well as aspirations towards standardizing contracts, things like that, where if we work together, there's just that power in numbers. So I just wanted to reinforce that point.
Very important point.
And once we do that, it helps us with the funding overall when we get more efficient.
Very true.
In fact, talking about early career, so like the platform that we've created, letsgetproof.com. So one of the aims of it is to provide opportunity and inspiration for young people to get into the world of research, because sometimes there can be a sense of disillusionment related to the hill that is there to climb and the difficulty in getting it going, kind of thing. So that is how we've sort of created it. It's for collaboration. But compared to other aspects of our overall human existence, the one part that I think we underutilize is crowdfunding. And you mentioned the idea of trials not getting completed because of lack of funds. And really speaking, we've been struggling with this for now 2.5 years in convincing people that we are not utilizing crowdfunding adequately. The big platform in North America, US, is GoFundMe, and they have more than 20 million transactions per year. And there are people who are highly successful, but somehow it is not ingrained into our culture. And with that in mind, we created this platform. And even now we are struggling, young doctors and all, they say, yes, I have a project, I need this, and so on and so forth, but it's not part of our culture to be able to market ourselves, to get multiple small donors to fund our projects. And I think that is going to be the way to go, because ultimately industry trials are industry trials, and I've been involved in many of them, and they'll fulfill a purpose, but they have a specific agenda related to the success of whatever that industry is trying to do. For us to do purely academic trials, we have to continue to look for additional resources of partnerships and funding.
Yeah, that is true. And also I think part of collaboration and then network interaction helps to facilitate that, and also to see how it works in other countries. In the UK, for example, I think kind of crowdfunding works through support to charities, and then charities again support research.
Yeah, I mean, I think the thing we've just touched on about raising the profile of stroke research is really important. In the UK, the majority of the money does come from the government or charities rather than individual things. But I think one of the reasons stroke struggles for money and profile is there are some things for stroke research that are more difficult, such as consent, etc. And we all have different geographical regulations. And I think by working together and sharing good practice, our kind of partners in regulation have more confidence in approving a new approach if they've seen it's been used in other geographical regions. And I think that's some way we could work together as well and improve that. And we've had experience of that.
I do want to point out that at least in Canada, charity-driven gathering of money and distributing it still, so to speak, favors the rich getting richer. People like me put in grants, and if you have track record and profile, so it doesn't help the underdog. It doesn't help the young investigator to the same extent.
To start something.
So that is what also we have to do, is to create the next generation of people interested in research who in due course will reach there, get them young, get them interested, get them a sense of accomplishment. And to that extent, I do find the grateful patient model, or the model of using your personal contacts, etc., etc. The traditional crowdfunding is in my opinion what we should be changing the culture to be able to do that.
Yeah. I think while developing and helping the next generation, that's an important, really important task we all have to do. And maybe Jean-Marc and Pooja, do you want to tell us a bit about how your network, how your alliances help to educate the new generation? Because there's a lot you both do.
So with StrokeNet, we're fortunate to have dedicated funding through the government to actually have each of our regional hubs, we have 27 of them, have a StrokeNet trainee each year. And they're called StrokeNet trainees, but they can be early career faculty. They're people who want to do clinical research and clinical trials. So we have a robust curriculum. I'm pleased to say we have a great track record. A lot of them stay in research. In fact, some of our most recent StrokeNet trials are funded by people who went through that program. So we're proud of that. And I'll mention that those resources are public, some of those educational resources, and we've tried to make them prominent on the GAINS website as well as our StrokeNet website. So I hope people can take advantage of that.
Yeah, I think that is an important information. And same for ESOTA.
Yes, I think this is a new direction that we discussed 2 days ago during our common meeting. I think we should go in Europe doing the same thing. We want to integrate more young mid-career people into ESOTA, and this is what we're trying much to do. We have also now a teaching session that is embedded into the ESOC that will take place at 5 p.m. today, and there will be nice talk from very experienced stroke researcher, and we do think that also education to research is something that is very important. In addition of getting the money and from what I've seen from your website, many of the research that is done by young researcher, and it's gathering seed data that then you can use to apply to something bigger and to test an idea without having to go through the funding agency and all that it takes.
Yeah.
If I might just add,
please.
such an opportunity to share this occurred to me. You know, Jean-Marc and I were just at the GAINS meeting where one of the things that is happening is the next early career workshop. It's going to be in Abu Dhabi, and it's being led jointly by World Stroke Organization and GAINS, and at the helm are Andrew Demchuk, who's been a wonderful leader to next trainees, as well as Roland Volkamp. And so I hope that some of the people who are listening that are early career will consider coming to that one-day workshop that's going to be right before the World Stroke Congress.
And as mentioned, I mean, both websites and your platform, they give an excellent opportunity to learn more. I think Jean-Marc, ESOTA is very open, that committee. You can be approached by young colleagues who are interested, same for GAINS. I think that is, there's always a possibility. So actually we would like to encourage all young stroke interested researchers, please approach us, approach experienced trialists.
Yeah, I was just going to say not just researchers though, because we've got to have clinicians in the clinical services recruiting these patients and taking part, and they've got to feel engaged, because if they feel it's an us and them, it doesn't work.
That
so
is definitely true.
Really want to reach out to clinicians as well. We want to work with you. We want you to feel valued.
It's a big
teamwork. And I'm
teamwork.
so glad you said that, because when I spoke about our success in training researchers, I think of the people who are enrolling in trials, not that necessarily the people who are writing the grants and running the trials. We're all researchers together advancing knowledge.
Absolutely true. Absolutely true. And depending on in which country you work, either actually that is one person. In Germany, for example, they are all one person. But in some countries, that's a bit different. Academia and clinical work is a bit separate. So clearly, we are one team, and everyone is absolutely needed. Otherwise, we will not make one step forward. And we've heard today in that presidential session how important it is to all work together so that we can make it better for our patients. And with that, I would like to thank you very much for coming and for discussing that topic today. And I wish you a very nice rest of the conference.